Hi, guys. Thank you for joining. This is Essence of History, and today we're talking about the history of surgery. I'm Amanda Armagost.
I'm Dr. Bassi for Essence. So, Amanda, have you had a general anesthesia and a surgery? A regular surgery, not a procedure, small procedure, but a surgery.
Yeah, I've had two surgeries. And I was under general anesthesia for both. It wasn't just like local or anything. I had my tonsils and my adenoids taken out, and then a few months after that, I had my wisdom teeth taken out. So nothing major.
Oh, well, well, what would what if I would tell you, something like what you just described, not long ago, would have had like 10% mortality or 1 in 10 person would die of it. Not long ago, few hundred years ago. What
That
would
wouldn't that wouldn't surprise me in the least.
Yeah, yeah. Now, what what do you understand under surgery? When I talk, I just let's define the words we are going to use. What is a surgery for you?
For
Versus a
me,
procedure. Surgery versus a procedure versus a
I guess I think of surgery, I mean, a little bit bigger than a procedure. I think of surgery as something where you are opening up the body and placing or removing something. I guess the same for a procedure. Like, for example, I had something taken out of my arm earlier in this week, and that was technically a procedure, but also they've referred to it in the doctor's office as a minor surgery. So I really don't know the difference.
yeah, well, the definitions are very fluid. Like we in our surgery center, we perform a lots of things that we call them procedure just 50 years, not just 30 years ago. That would have been a major surgery. Let me describe to you one of them. The first time I was involved in a lumbar fusion is what it was a 7 hour surgery with my attending, and we lost about a gallon of blood, which we had to transfuse a lot of blood, lots of blood product. That patient stayed 4 days in a ICU and then about 2 weeks in the hospital. 20 years ago. Sometimes you come to our surgery center, you watch that surgery, and you understand that that surgery is now, we do it in literally 30 minutes, and we lose like 2 spoons of blood and send the patient home within 2, 3 hours. Now, obviously, some people still do that surgery the way I did it 20 years ago.
Hmm.
They think that's the way to be done. But we made that 7 hour surgery with the ICU stay a procedure, small procedure. I think it's about how extensive that process is. Both of them include penetrating the skin, performing something under the skin, and in most of the time, if you need the general anesthesia, it's called surgery.
Hmm.
And if you don't need general anesthesia and it can be done with the local anesthetic, we can call it procedure. Like another procedure is the sacroiliac joint fusion, where even 10 years ago, 20 years ago, it would have been a tremendously bloody surgery. We do it now in our surgery center again with local anesthetic in 15 minutes and send the patient home an hour later. So
Right. So would
you
you
do it to a procedure.
so you consider your SIJ fusion a procedure, not a surgery?
Yeah, you see that those terms are very fluid. Is
Because I, as like a layman, I would consider it more of a surgery. But
Mhm.
when you compare the two, I mean, an SIJ fusion sounds like a walk in the park compared to a colonoscopy because with a colonoscopy, you're under general anesthesia and it takes 30 minutes. And a,
Um, yeah, obviously, now how long it takes, how invasive it is, how fast you recover from that. But that procedure versus surgery is a new distinction.
okay.
And it's a fluid thing that many things that used to be a major surgery now are small procedure, and we are approve of it. But you see, the major point there is if patients under general anesthesia. How long do you think we have had general anesthesia?
50 years?
Um, we had general anesthesia in the modern sense for, I would say, 70 years, but 70 years is not that long. Many people are still alive.
Well, and you and I both know that even for regular surgeries, some people don't use anesthesia, like in India.
Yeah. Um, well, that is it. But at least we have the technology.
Oh, I guess they don't use opiates.
They do use opiate. They use the general anesthesia now.
Yeah, they use general anesthesia, but not opiates.
But surgery, in a sense that we perform today, is an absolute marvel of technology.
Totally. Mike was just showing me a video upstairs of some, I think she was, I'm going to misquote it, but 97 years old. And she got a two-level fusion awake.
Okay.
And
Uh,
think about that. Hmm?
are you talking about one of my patients?
No.
Okay.
It was, she was like completely awake. Like she was, the positioning for an epidural when you were just hunched over.
Okay.
She
Okay.
was like that. It would happen this week or something. She was like that during surgery, just hunched over, awake during it for a
Mhm.
two-level fusion. It's crazy because when she was born, if someone would have said that to her mom, like, yeah, in 90 years, your daughter's going to be getting the surgery, her mom would think, no way. It's amazing how fast medical procedures can evolve.
Now, what do you think the first surgeries that we have approve of?
Well, we've already talked about this. It was brain surgeries.
Yes, yes, but what do you remember about it? What we talked about?
Um, for example, if someone was working on the pyramids and they got injured and they fell and they needed some release out of their head. So then they made a small incision and that was technically brain surgery or broken bones was another big one, like pretty much casting.
Yeah, well, broken bone was mostly casting. Is it a surgery? I doubt it because you don't penetrate the skin and so on, except skin is penetrated already and then you pull it. But trepanation, that's what you're referring to. Obviously, when they were building pyramid in Egypt, um, they have found main to the close to the main pyramid, they have found skeleton of lots of people that now we know they were most likely lower level people that they used to work there, and when they died, they put their just corpses there and so on. They didn't. Some were mummified, some weren't mummified. But what interesting thing is that when they looked at their skull, there is a hole in the skull, but the edge of the bone is has grown for a year or so more. So these people survive this, what we call making a hole in the skull. And what we know now is that if somebody, like that, for example, falls or get clubbed on the head, they may bleed in a very specific way. We call that epidural hematoma. And one of the first sign of this epidural hematoma, if it's in the right place or wrong place, you call it, they start seizure, meaning convulsion.
Okay.
Somehow the Egyptian found out if you make a hole in the skull, these people survive. The way they justified that is that they were opening the skull for the bad spirit. They thought this person is possessed by demons, and that's why they are, they're convulsing. Somehow they figured out if they make a hole in the skull and let the demon out, these people survive.
You know what's really interesting? I was just reading today about like the history of whatever, like spinal medicine, period. And I guess that used to be a historical way of treating people with demons for the spine too. They would make a small hole in the spine apparently to let the demon out. Do you know
I
anything about
mean,
that?
lots of bloodletting and lots of this kind of activities that we have done in the past, most of them were more damaging than really good for the patient. They were based on observations, meaning medicine is not really an exact science. It's more art than science and a lot of observation. Now, um, eventually, people observe that certain situations, certain symptoms are alleviated or get worse with certain thing we do. And then more and more, we can consolidate that by repeating it somewhere else. Somehow the Egyptian 5,000 years ago figured out when people fall or get clubbed and then they start seizing, opening the skull can save their life, and so they did. Now, many of that knowledge was lost, and uh, we have very little more information about how surgeries were done. But um, there was and then let's come to the time of the Greeks and the Romans. Um, when the Romans, in their armies, obviously they had a lot of injuries, and a lot of those injuries were actually treated with hot iron, like cautering bleeding limbs, and maybe doing amputation and so on, and then sewing, like they open up slash open their belly, you just put it back and you sew it with different material and so on. So over the years we gathered a lots of information about how to do actual fixing of things. Now I'm talking about the time that um, human life wasn't really worth much, meaning that they would go to the gladiatorial, arenas, and they would slash each other open. Well, they saw it with whatever they had. Even if um, just one third of them would survive, that's better than all of them die, because alternative would be everybody dies.
Sure.
And now bone setting, it was very early on, very important part of practicing medicine and surgery. But what I want you to understand is that surgery and being a physician, they were separate paths. Like a respectable physician would not do any surgery.
Yeah, weren't like even barbers doing surgery? And
Mhm.
that's why the blue and red spirally thing outside the door exists?
Well, we will come back to that. Even today in England, when a doctor, medical doctor, become a surgeon, he gives his doctor title away, and it's called Mister. Like, I would be, after med school, I would be Dr. Abbasi. Once I'm done with the surgery, I would give my title of doctor away. I would be Mr. Abbasi. And if you use the word Mr. Abbasi in a hospital, is a different meaning than a Mr. Abbasi in another business and so on. So it's not everybody can be called Mr. because if you call in the hospital somebody Dr. Abbasi, he's a non-surgeon doctor. But if you call him Mr. Abbasi, he is the surgeon. So, and that is because before, as you said, a respectable physician would not perform surgery. They would send it to lower level barbers because barbers would have sharp knives.
Mm-hmm.
And 90% of the what the barber or what the surgeon would do is, do you know what is the most performed procedure used to be?
Um, yeah, bloodletting.
That came much later, but it was there is a Latin phrase even for it. It was from time of the Socrates, which was in Greek and then went into Latin. By the way, Romans, they didn't do anything themselves. They just overtook the culture, technology of other cultures.
Mm-hmm.
Very poor history of humanity.
Yeah, there's still some cultures like that these days, I feel like, but I won't mention them now.
So there's a Latin phrase called obi pus ibi evacua. If you put it together, you can make sense of it actually.
Yeah, getting rid of pus.
Wherever pus, let it out, evacuate it.
So if you had like a boil, like some type of wound, then you go there and they open it up.
Slash it open. That's what the
Okay.
barber would do. You would go there, you have an infection under the skin that can kill you. What they would do, they take their sharp knife, they slash it open, the purulent, the pus comes out, and then you don't die. And that is why a respectable doctor wouldn't choose a profession like that.
Yeah, because that's gross.
That is not only gross, there is a little brutality in it. A gentleman would never give itself to. Now, and the fact is as well, uh, even in those cases that they would attempt the surgery, mostly patient would die.
Immediately or like when?
Well, some immediately, some, painfully over a period of time. One of the things was that the doctors, the surgeons, not the doctors, has to be extremely fast. Like when you're doing amputation, you have to be extremely fast because if you're not extremely fast, the patient will go to a pain-related shock and die.
Yeah, it's pretty much torture because, like you said, there was no anesthesia.
If five people are holding you down while somebody is cutting your leg off, imagine that. That's all what it is to it. Now, there is actually a historical. Um, you know what mortality means? Mortality.
Mortal, like
That means the rate of death. Like, let's say Ebola has 95% mortality, whereas COVID 19 had like 3 to 5% rate of mortality. Do you know what that means?
3 to 5% likely that you're going to die.
From COVID, and 95% of people uh, who get Ebola will die. Meaning, now, what if I told you there was a procedure in Civil War that the mortality of that procedure was 300%? What do you understand under that?
Everyone dies.
But 300%, like if 100 people get that, 300 people die. What does that mean?
I don't know.
It's a joke. It's a joke. Now, it was this doctor, surgeon, very good surgeon, was amputating a gangrenous, infected leg of a soldier, and he had to be so fast, and he was fast. During that surgery, he actually infected his assistant and himself. So not only the soldier died, but both of them died as well. That
Just
makes,
like Ebola.
well, Ebola is 95%. This was
Yeah,
300.
but Ebola can't don't a lot of times don't like the doctors if you're throwing up on your doctor, then your doctor's likely to die and same with the nurses and things like that.
Yeah, it is. But then you have Ebola. Then you are part of the statistic.
Right.
Here, I'm okay. Well, that's actually an internal joke among
Okay, yeah, it's a nerd
surgeons.
joke.
And now it's a doctor joke that surgery, specific surgery, had 300% mortality. Now,
Sure.
but that was the reality for surgery. Okay, most of people who got injured in civil war, people had to hold them down so they could do their job, and that's unimaginable for us now.
It's pretty brutal.
That is brutal. That is absolutely brutal. And but surgeon got eventually good at it, and then eventually the doctors took it from the barbers and other profession, and with understanding of the anatomy, we could actually do something good. Because I'm not sure if you know, in most of England and Europe, where our medicine is coming from, doing autopsy was illegal.
Why?
Um, Religious reason and other reason. As a matter of fact, it was always a shortage of corpses for anatomy, to a point that lots of people would do grave robbing,
Yeah.
stealing the corpse, so they can sell it to the um, the med schools and so on, so people can learn that. As a matter of fact, eventually in England, they decided that the people who are condemned to death penalty, their corpses would be given to the anatomical lab, and then the people would bribe judges to impose more death penalty so they can have corpses. Can you imagine that? There's a
So
dark
was
history
back
in
in the day
medicine.
like a normal person couldn't just when like be a donor.
No. No, it wasn't like that. People would, as a matter of fact, go grave robbing, and some people, because they didn't want to dig graves out, they actually go kill people
Hmm.
to be able to sell their corpses for anatomy labs. And doctors, closed both eyes and accepted those corpses because we were so desperate now. And
Wait,
because,
but sorry, can you imagine what a weird train of thought? Like, oh no, I can't dig a grave, but I'll kill someone. Like,
but no, but it is less work. I mean, no, seriously, for somebody who has no moral value, killing a person is less work than digging a 6 feet grave or something, right?
okay. I mean,
You
I've
just
never
put the
done
rope around,
either, so I
you
wouldn't
make them
know.
drunk. That is what they did. No, seriously, that's what they
Yeah.
did. They make them drunk. They took them to a tavern, gave them alcohol, made them drunk. When they passed out, they put a rope around their neck and they choked them, and then took the corpse um the anatomy thing, and they sold it.
Wow.
And some of them did even something more. Then they called the police. Then the police went and took the dead, came and buried it. Then they came in and dig it out and sold it again. These are all happened. As a matter of fact, in Houston, in Boston, it was a few riots in Boston and New York. There were riots about against these doctors because that would become something that there was a these doctors would buy the corpses, and so there was a profession, grave robbers. So people actually wanted to lynch many doctors in Boston because of that.
But I
So
mean, we did benefit from it at the end of the day.
they did, but you understand why being a surgeon wasn't a very respectable thing.
Yeah.
So um and so um but anatomical knowledge improved tremendously, and that was one reason that surgery became something respectable. And another thing that really changed it was introduction of anesthesia, general and or local, both. Now, I think it was Louis XIV, the king of France, where there's a huge history about his dental work, mouth work, and so on. And it is when you read about what was done to him, it is actually almost like a horror story that his teeth were removed. When they removed the teeth in without anesthesia, they opened up, they broke the jaw, and then there was an opening from his mouth to his nose that when he was eating, the food would come out of his nose. And
Who was that?
14, I believe.
Why'd they do that?
But it was all decayed and so on. It was infected.
Oh, okay.
Yeah, and then it became like a fashionable thing, had not having teeth in the mouth. Then so I mean, imagine. I mean, it was a crazy town. It was a crazy town, and but all of that came from, surgery being a horrendous thing that 9 out of 10 times would cause more harm than good. First, with our understanding of anatomy, and then with general anesthesia and local anesthesia, the surgery became moved in the direction of science. Now, all of a sudden, we understood that there are arteries, there are veins, there are nerves, there are connection, large intestine, small intestine, that that we understood that what is this safe strategy to achieve a goal without killing the patient. And that's what today, as well, the surgery always is. Finding a path in all our structure that are in our body, bypassing anything that if you touch it will kill you, get to the place where the problem is, solving it the problem and closing it back up in a way that patient survives it. Now, there are millions of surgeries performed in the United States. Just you found out that how many spinal surgeries are performed in the United States, you found that out.
Well, that's like old information now. I found that out in like 2022. So imagine how many more are performed now. And that was 1.6 million a
That's
year.
spine surgery. That's
Just
instrumented spine.
instrumented spinal fusions.
Yeah. And um, what if I told you there were just 100 years ago, the mortality rate of the spine surgery was 30%.
I would actually be surprised because to me I would have thought it'd be way higher than 30% 100 years ago.
Well, we didn't do that many of them because of that.
Yeah.
Okay. So not many people died, but like doing a spinal fusion 100 years ago would be a whole day surgery.
Oh, I bet a like 6 month recovery. I bet it was an insane, like I bet your whole body was inside some type
It
of
was
cast.
6 month recovery even is even now if you do it the traditional way.
Yeah.
So it was even 30 years ago, before we had like these screws that hold your spine together, it would be 6 months before you could walk. By the time you could walk, you had no muscle to walk with because not using the muscle for that long, they all atrophy. So our understanding of the anatomy and then the anesthesia, and obviously everybody knows chloroform from these movies where you put it on a handkerchief and you put it on the mouth and they just follow.
I think anyone with a mom knows about chloroform because your mom is like constantly warning you about it.
But what if I told you there's nothing like that? It is not like you put it on a piece of thing, you put it on the mouth, and they init right away. You have to hold it for 3 to 5 minutes, and they cannot fight it. It's hard to hold something in somebody's mouth for 3 to 5 minutes. You
Yeah,
know,
I can imagine.
imagine for 5 minutes.
Right. Like slam your head back.
Yeah. Um, so, but toward about 150 years ago, we had chloroform, we have ether, we have other things that we noted that in a proper dose, literally, you're unconscious, you don't feel the pain, and and later on there was another revolution. We found out from some Native American in especially Amazon that they use darts, poisonous darts. They make their darts poisonous by rubbing it against the skin of a special kind of frog, very colorful frog.
I've seen those frogs at the zoo.
Yeah. And they put the darts on that. And then if they shoot it at somebody, those people cannot move. But that's not it. It's much, much more horrific than that. They cannot move, but they feel everything. They're not unconscious. So there are stories that they would do that to their enemy. They would use the poisonous dart, and that material, what curarium, it's a muscle relaxant, we call it. It separates the ability of your nervous system to control your muscle, meaning your brain is there, you are aware, you're sending the signal to your arm to move, but at the end of the nerve, where the nerve goes to the muscle, says contract, it removed that um, ability. So these horrendous stories are that they would poison them and then put them on an ant colony, and they have lots of nasty ants in Amazon. And these people, they cannot move, but they feel every little bite
Mm-hmm.
of those toxic and fire ants. And what a horrific way to go, huh?
Yeah, terrible.
Human do that to each other. But now imagine doctors, they came out and found out that, well, these people are unconscious, but still the muscle move. They don't, like, imagine you have to do surgery on somebody who's moving. He's not conscious, but this is the unconscious motion. So the
Mm-hmm.
third revolution in the medicine, so in the surgery, came from our ability to be able to keep the patient literally still during the surgery. And then about 100, years ago, when electricity was wide, available, we used it for both things, for healing and for killing. I'm sure you have heard about electric chair, right?
Yeah.
Yeah, but there is another part of that we use for electricity. We call that electrocautery, meaning that, and there's two ways of doing that. That is the fourth revolution in the surgery, where we put a pad, a electrode, wide electrode on a patient,
Hmm.
and then the other part is like a small little pen. Imagine the whole electricity goes through a tip of a pen, and then in that moment when it's passing through that little piece, it creates a lots of very local heat. Because we knew, like the Roman did, you make a piece of metal really hot, and then if you put it on bleeding wound, it stopped bleeding. We knew that. But that would cause a lot of collateral damage. Now, by putting a big pad on one area and then a small entry point in one other area, then we could concentrate all the heat at the tip of that, what we call BOVI or monopolar coagulation, and then we can stop at one small artery or something.
Sure.
And then later on, we found out, hey, why not to make something like a forceps that the two tip are two different part of the electrode, like this two. The electricity flows between them, and it only heats up the area between them. That becomes even more precise of a way of um, stopping the bleeding. And then I would say with this and the next one is with the concept of monitoring the patient, the modern surgery was born.
And when was that? What year do you think? Or like
In the
around?
United States, we start doing this kind of surgery about 100 years ago, 110 years ago, starting doing all of that. Obviously, the technology evolved and so on. And there's a picture actually I made a TikTok of it. The father of neurosurgery in the world is by all regards is the so-called doctor from John Hopkins, Harvey Cushing. And you see still one of the reason he was the father of the neurosurgeon in the world is because his patients survived. Because not all his patients recognize my word, not all his patients died. Okay.
Right.
And you see him as well. He has like a cloth in front of his mouth and he covered his head. Because before that, the idea of obviously one other revolution that we didn't talk about is the antiseptic kind of approach to medicine.
Hmm.
You and I, we did that podcast about Ignaz Semmelweis.
And we bring him up like socially pretty much once a week.
Yeah, yeah, and that is because what he did, he actually um, modernized the not only surgery but medicine as a whole, but as well how the establishment reacted to him, make him the hero he is.
Yep, exactly.
Fact that he was willing to fight the establishment and say, yes, your hand, gentleman hand, can kill patient. And he was willing to go to the street of Vienna, give flyers to the woman, them asking them to demand their doctors. Imagine that. He would go there and ask, put flyers in the hand of the pregnant woman in Vienna so they can demand their doctor to wash their hand
Hmm.
before the procedure.
That's just so crazy nowadays to think about.
Yeah, and that is just 100, I think about, yeah, 150 years ago. That's not that far. That was around the time of Civil War. Okay, maybe a little before.
I was reading today that World War One and World War Two really brought a lot of medical innovations to us. That because of World War One and because of World War Two, we are where we are today, medically and surgically.
Absolutely true, especially surgically, because was the first time that human life really mattered in the sense that you're not just accepting your soldiers to die just because they got shot. How can we help them? Okay.
Yeah.
So antiseptic, anesthesia, muscle relaxant, electrocautery, and then one really sealed the deal was antibiotic. Now, um, there was a in Iraq-Iran war that was 1980 to 1988. It was an observation that was actually put in papers and so on that there was a certain area that Iraqi, army would move forward, then Iran would go back and work, and in that action there were lots of soldiers between. They would stay there. What was observed is that those soldiers that they in the wound, they had maggots. They would survive. Those that they didn't, they would die.
Because the maggots were eating the bad part, right?
Well, the maggots are competing with the bacteria for the dead flesh,
Hmm.
and the bacteria would cause sepsis and kill the patient, whereas the maggot just would eat only the dead flesh. And by doing that, not only they would not give any medium for bacteria, but as well they would produce some macrobiotic antibiotic material because they're competing with the bacteria.
Right.
Okay, so um, we knew for a long time certain things that would reduce the risk of infection after you open the skin. But obviously, first in World War II or just before it, we fully understood the concept of antibiotic. And what did we use? We didn't use maggots. We could have because they do produce some antibiotic, but we use fungus, which is much more universal, easier to grow. Literally, um, what Fleming observed is that on these petri dishes, that when there is a fungus growth, in certain distance to the fungus growth, bacteria are not growing. And then when he isolated penicillin from that, it became the hottest substance in the planet. All of a sudden, your soldier didn't have to die. No, it was so sought after, so valuable. They would take the urine of the soldier who get penicillin to take that penicillin out of it again so they have more penicillin.
Wow.
Imagine that. That was so valuable.
And we still use it today.
And we still use it today, but we have a lot of other things. I mean, generally, penicillin itself is not it's being used for very few things these days because we have better things than that. But that was the start of it, and it's still
Right. And I don't want to get into it right now, but a lot of people are allergic to penicillin.
yes, they are. And then, but that is a different story. But we should talk about that. But so now we have all the pillars of a modern surgery. We have antiseptics, we have antibiotic, we have understanding of the anatomy, we have electrocautery, we have general
Anesthesia.
anesthesia, and we have muscle relaxant. And guess what? All the surgeries are today done with those five elements that make the surgery possible, small or big. I'm pretty sure they numbed up your arm before
Oh,
they
yeah,
start.
they gave me a shot and numbed it. That was the most painful part was getting the shot.
Yeah, yeah, and in general anesthesia, we use other material that overall, put your nervous system in a position that you are not there to conceive the pain. Do you know, by the way, how those general anesthetic gases and so on, do you know how they work?
How?
We don't know. We
Even you
don't really know.
just magically works.
They just work. We have an idea. We think they go to the membrane, those gaseous anesthetic, they go to the membrane of our entire nervous system and reduce um, their activity level and so. But how they exactly work, how it comes that you give certain amount of this gas to a patient like isoflurane or something else, sevoflurane, and then all of a sudden they're unconscious. We don't really know. Now,
Hmm.
some of them are IV sedative like propofol and Versed, we understand that. We know what receptors they work at and so on, but this gas inhalation anesthetic, we don't really know. Now, there is something that you as well, I'm sure you have seen in the movies and so on, is laughing gas. Have you heard of that?
If you, yeah, in the US, they do that for dental procedures.
Yeah, it's still being used. Now, laughing gas is nitrous oxide. And it is exactly, we believe works the same way, going to the membrane of the nervous system and literally making us unconscious. But obviously, it is the old way of doing that. It's still being used, but in generally, in most of our surgeries, we have much better things than nitrous oxide. Okay, and why is it called laughing gas anyway,
And
Amanda?
probably makes you laugh.
Yeah, because in the border between not being you fully you and being totally out, there's a phase that all your social inhibition go away. The part of your brain that makes you not do crazy things, well, maybe that you're the bad example for that, but but that part is usually our frontal brain. And the frontal brain is a big part of it. When you start giving everything everywhere, frontal brain activity goes down first, but you are still conscious, then people start doing goofy things that they usually wouldn't do.
Okay.
That's why laughing gas is called laughing gas. Serious people start, having social disinhibition, meaning they don't follow the regular rules, and then they do funny or maybe awkward thing and so on. So that's the word laughing gas come from. Now, um, the last time I had a surgery was a hernia surgery. And what I noticed is that I was there and I was gone and I was gone because usually I don't sleep. That was the best sleep I ever got. I was completely gone. I mean, it was nothing there anymore. It was like a time machine.
Right. I know
And
that's
that,
how I feel too.
yeah, and that is how how advanced we are, how we are able to control different part of our body and function. And yeah, every time that happens, I'm in shock and awe how far we have come and the things we can do to human body. As a surgeon, it is for me still a marvelous thing what we can to do to human body. And yeah, like when we do a brain surgery or spine surgery, how many vital structures are just next to the place we are? And if we are few fraction of an inch to the right or to the left, horrendous thing will happen, and they don't.
Right. Because you
Because
understand the anatomy.
and we go like I tell one, not everybody is like me, but I went through 23 years before I was an independent neurosurgeon. After the high school, I went to 23 years of schooling to be independent surgeon, and I needed 3 more years, and that's a short period because most people need 5 to become a board certified neurosurgeon. So 26 years.
Yeah, but you want your doctor to have gone through that for sure.
Because even though we talked about this our anatomy and so on and so forth, it is not like 1910 that it's okay for 1/3 of your patient to die. Because if that was okay, we could learn that in 2 years.
Right. And most of us don't want to die. We want to survive our procedures.
Okay, well, that was a very short, that long history, short
It
history
wasn't
of
that
a
short.
long path surgery took to be able to even make Amanda be okay with going for surgery. Imagine if surgery had a 1/3, 30% risk of mortality.
Yeah, but I think also whatever you're dealing with has a pretty high risk too.
Like what?
Like if you're seizing because your brain is flooding, you probably are going to die from that too, right?
Yes, yes, that's very
So,
true. Now, you bring something up that I think that's a problem of the modern medicine. You remember that we don't accept 1/3 of our patient to die. We
yeah,
don't
and then you
accept anybody to die.
right.
By not accepting anybody to die, now it has been bastardized, meaning that the surgeon don't do the surgery because they don't want this patient die in their hand.
Yeah.
If the patient dies 2 weeks later on the consequence of their disease, then unfortunately hospitals, doctors, then can push the responsibility away from themselves, then they're okay with that. Does that make sense, what I'm
Yep.
trying to say?
Yeah, I understand what
Has
you're trying.
backfired. It has backfired. The idea is to give the idea, original idea is to give the patient, that specific patient, the best chance.
Yeah, and the best quality, I'm assuming.
Best chance of the good quality extended life. Not the miserable extended life, but good quality extended life. Like a patient comes to me who hasn't walked for 10 years and has a horrendous spine and has heart problem, lung problem, and so on. And every surgeon refuses to do surgery for that patient, not because we don't think he doesn't need surgery, but we don't want a bad result tarnish our reputation and go in the hospital, explain to some administrators, and especially, some of our colleagues who are even worse surgeon, why my patient had a bad outcome.
Mm-hmm.
Same patient literally can have a heart attack in 2 months because he cannot walk, but then nobody will blame me.
Or even something else that's not going to show up on the medical scans or anything. What about that patient's quality of life mentally? Like they can't leave the house, they can't work, they can't do anything. They have no friends now.
May
Imagine.
them commit suicide. That's
Yeah.
not fair at all. No, I'm sure you have heard the thing that we talk about, the mortality of overdose, narcotic overdose. A lot of that is not overdose. It's a medically committed suicide by the
Yeah.
patient
Yeah.
because they say, okay, what happens? I quit breathing and I die. I prefer that to live like that, and they not only take the chance, they welcome it. I have had many patients who gather their pills, that every month they get pills and they save some of it with the intention to commit suicide. And this was a true story that, when I went and tried to explain to one of major insurance companies about what is the advantage, disadvantage of what I'm doing, that because I reduce the chance, the complication, the chance of bad outcome, I'm willing to give this chance to more patients. But whereas with the traditional surgery, you would never give the chance to the patient. The chief financial officer of that big company, big medical insurance company, said, "We know all about that. 6 months later, they have to get a triple bypass that is $500,000 because nobody wanted to do that $50,000 surgery that would make them mobile."
Right.
But the problem is that if the $50,000 surgery that would make them mobile has a certain high rate of complication, in this climate, nobody wants to take the chance for the patient. If patient die on the heart attack, is not responsibility of the spine surgeon anymore, and we can just shed it off our back. And I think that is really has become more or less unbecoming of my profession to do the safe thing, not for the patient, but for ourselves. But
Yeah.
that is a different story. That's a different podcast.
And hopefully that can be the next pillar of medical innovations.
And I think the next pillar of medical education and medical innovation is that for us to understand when we're doing risk versus benefit for patient, we don't just consider the risk of the procedure, but as well the risk of not procedure,
Yeah.
and add it to the combined calculation and make people responsible, meaning that, um, you can, as not people, not doctors, but the systems. Okay,
Well,
like
and I think the surgeon I mean, this is from a layman's perspective, but I think the surgeon also needs to become responsible too. If your patient came to you with these symptoms, this and that, and you turn them away, but you didn't say, I can't do it, but this. I can't do it, but this procedure can, or this doctor can. then you're kind of in a way like adding to the problem, in my opinion.
And I'm agreeing with you on that, that we as doctors, as surgeons, as physicians, as providers, it's our duty to give the best available information about what's out there for a patient, not best thing I can do.
Right.
Okay, so but unfortunately, the medicine is big business, and big business is not about uh, it's about care. It's about maximizing profit. But again, that's a different podcast. Let's conclude our podcast about the history of surgery.
Thank you guys for watching. This was Essence of History, and we talked about the history of surgery. I'm Amanda Armagast.
And I'm Dr. Abbas.